Daratumumab has been studied as a single agent in patients with relapsed and refractory myeloma in 2 separate studies. A combined analysis of these studies were presented at the ASH meeting last year. The first study, which is called the Gen 501, looked at 2 different dose levels, 8 milligram per kilogram and 16 milligram per kilogram of daratumumab, and patients with relapsed refractory myeloma were studied in that trial. The Sirius trial, which was recently published, again looked at 2 different doses and then proceeded to add additional patients at 16 milligram per kilogram dose. Between the 2 trials, a total of 148 patients were studied at the 16 milligram per kilogram dose. Overall, the response rate that was seen was roughly about 31% in patients who have been heavily pretreated. And it's very important to consider that over 90% of these patients have been treated with a protease inhibitor or an immunomodulatory drug, and about 85% of these patients actually had seen both these drugs and were refractory to both those drugs. And nearly 2/3 of the patients were refractory to a protease inhibitor, an immunomodulatory drug, and an alkylator drug. So clearly a very heavily pretreated patient group that have seen a median of 3 prior lines of therapy. So in this group of people, and the overall response rate was 30%. Among the patients who actually had a response to therapy, the median duration of response was a little over 7 months. So what this data clearly shows us is that this agent, by virtue of the fact that it's working through different mechanisms, is able to overcome the drug resistance to the commonly used classes of drugs. And these are the results which led to its approval in use in patients with relapsed refractory disease. The median progression-free survival in these daratumumab 16 milligram per kilogram combined analysis was roughly about a year, and the median overall survival for these patients was roughly about 19 months. So clearly, these patients with relapsed disease not only have a good chance of response, the patients who are responding also had prolonged response and significant improvement in their overall survival compared to what we would have expected for that group of patients. An additional analysis that was performed also looked at the outcomes based on what degree of response these patients had. So the patients who actually had a complete response to therapy, the median progression-free survival and the overall survival was not reached, and the patients who had a partial response to therapy also had significantly better overall survival and PFS compared to the patients who did not respond or had lesser degrees of response.
The most common adverse event seen with daratumumab therapy is the infusion-related reactions. As I alluded to before, the infusion-related reactions with daratumumab appear to be somewhat unique. They almost manifest as like a severe seasonal allergy type of episode in some patients. They may start to have watery eyes, runny nose, nasal congestion, a tickle in the back of the throat, perhaps associated with a cough, and in somewhat more severe cases, you may actually see wheezing and some shortness of breath as well. And the reason why we think that that may be the case is that, again, there are basophils, lining, the nasopharyngeal passages and upper respiratory tree, which have CD38 on them, and degranulation of these things, may mediate some of the effects that we're seeing. There again, the pre-medications with the montelukast, as well as the corticosteroid, the acetaminophen, and the H1 blocker do seem to help mitigate that. So if you do start to see some of these symptoms emerging in your patient, you do need to stop the infusion and let things simmer back down to normal, and then restart the infusion at half the rate, to prevent the adverse reaction, the infusion-related reaction, from getting worse. So we will see infusion reactions in about 40 to 50% of patients that are treated with daratumumab. Again, this is a dose 1 phenomenon. If you see it with the first dose, that does not translate into infusion-related reactions with dose 2 and beyond. There, they are very infrequently seen, and at most 3% of patients, and even less with dose 3 and beyond. As far as other side effects of daratumumab are concerned, you may see very modest effects on blood counts, modest leukopenia, very modest thrombocytopenia, but those things have been seen. In addition to that, daratumumab will bind to red blood cells. So red blood cells have CD38 at very low levels on their cell surface. You do not see hemolysis as a result of this engagement. However, The indirect Coombs test or indirect antiglobulin test, the screen of the type and screen, will turn positive when you start daratumumab therapy, and it will remain positive for 6 months after the last dose. This is not necessarily an adverse event as much as it is a logistical issue. So typically what we'll make sure that we do is get a type and screen before patients start daratumumab therapy. We also get a red blood cell phenotype. This will allow us to make it more easy to transfuse these patients once they start daratumumab and their screens become positive. In addition to that, we have our patients carry a card in their wallets basically explaining that they are on daratumumab, and it also lists what their blood type is in case they have to get transfused at a center that may be less familiar with the effects of daratumumab on transfusions.